Moving on, gestational carriers is kind of the final topic we'll talk about in the third-party reproduction unit here. Gestational carriers, also known as surrogates, these are people who do not intend on rearing the child, but they provide essentially a uterus for an intended parent who has some contraindication to pregnancy or some other issue, and they are not able to carry the pregnancy themselves. So indications for using a gestational carrier for the intended parents would be hysterectomy for whatever reason, be it cervical cancer, they have one child, but the woman unfortunately suffered a postpartum hemorrhage that was so bad during her delivery that they had to do a hysterectomy to save her life. Someone who had such a bad pelvic infection or instrumentation that her uterus is rendered scarred and non-functional. Medical contraindications would be as simple as, someone had pulmonary hypertension and they have a 50% mortality rate with pregnancy. So that's someone who should not get pregnant. People who have lupus nephritis should not get pregnant, most likely. People with bad Wegener's granulomatosis is another example of an autoimmune disease and someone who maybe should not get pregnant. I mean, again, these are case-by-case scenarios, but medical contraindications are a big reason. Bad obstetric outcomes, like a patient who has multiple fibroids, prior surgery on those fibroids, uterine rupture, and loss of the fetus during birth. These are reasons why people might not be good candidate. Like, she can probably get pregnant, but probably shouldn't get pregnant. Same-sex males obviously need a gestational carrier. And then, people who are born without a uterus need a gestational carrier. Carriers can be known, or you can get them through an agency. I think the cost is obviously the big question that a lot of people have. Honestly, if you know someone that's willing to be a carrier and doing it out of the goodness of your heart, the real cost is not that much. It's probably somewhere between $4,000 and $5,000 plus legal fees. And, the contract that you come up with between the intended parent and the gestational carrier might have some stipulations where the intended parents will pay for your gas and food and everything while you're pregnant, but you're not asking for some lump sum for paying for your time. If it's through an agency, these are usually people that are semi-anonymous carriers who you're basically hiring to do this job for all intents and purposes. In that case, the cost goes up significantly to the order of $85,000 to $100,000 to use the gestational carrier. And those are estimates, obviously. Gestational carriers ideally should be under the age of 45. They should have had a prior live birth. Probably not a good idea for someone who's never had a live birth to their first experience with pregnancy be one in which they are not going to be the parent. That may be not optimal for the intended parent and or the carrier. I mean, that just increased risks across the board. You don't want the carrier to have had multiple C-sections or multiple vaginal deliveries, as that can increase some obstetric morbidity. And then everybody has to undergo a psych evaluation. And again, if you want more information about what it takes to be a gestational carrier, again, you can go to this website from the American Society of Reproductive Medicine, and you can read about recommendations for practices utilizing a gestational carrier, and it lists kind of what the indications are, what the screening involves, etc. And it's pretty involved. Obviously, this is, recreational reading at this point, not something I'm going to quiz anybody on. So I think, the best way to really apply your understanding of the menstrual cycle is how we manipulate and amplify a menstrual cycle in assisted reproductive technologies. And we talked about that in the prior lesson about IVF. We talked about it with frozen embryo transfer. We even talked about it with ovulation induction agents. How those agents work and how we help couples with infertility or other fertility issues conceive is all based on an understanding of how you harness the menstrual cycle. So we talked about a scenario in which an egg donor and a recipient went through a cycle. We're just going to kind of go through a similar scenario where a woman and her husband are creating embryos that are then going to be placed into a gestational carrier, which is not that different from the scenario in which you have an egg donor going through a cycle, and then those eggs are being fertilized by the husband and then transferred into the recipient. This is very similar, but I thought it would be a good way to just kind of put everything together and wrap everything up into a nice bow. So this is the last slide here. A lot going on here, so follow with me. But basically what we have is, let's just say we have this 30-year-old woman who has Müllerian agenesis. Her and her husband are ready to have a baby. So we need to create embryos from the with the intended parents, and then those embryos need to go back into the carrier. So we have to prepare the carrier's lining to accept the embryo, and then we have to create the embryos. This process we're going to show in this scenario is broken up. The top part is the intended parent, and the bottom part is a gestational carrier. And we're showing it to you in a strategy in which we're doing everything all at once in a fresh cycle. Because embryo freezing is just as good as fresh embryos and the technology has advanced, the need to do it this way has lessened. You can essentially break this process up where you can create the embryos in one cycle, and then once the carrier is ready, transfer the embryos into the carrier. So it's a lot easier to do it that way for all parties because you're not relying on everything to be done all at once. You know, if the intended parent's age is becoming a factor, you might want to create the embryo sooner rather than later instead of waiting 6 months when, you know, a 37-year-old woman is now 38, for example. But again, just for the purposes of understanding this, we're going to demonstrate the process in a fresh cycle. So we're going to start with the gestational carrier. And what I've noted here is these letters are key events in the process. A and then A prime. The primes are for the carrier. The non-primes are for the intended parent. So if you'll notice, both people have to be on birth control pills. The carrier has to start first. So once their cycles are synced up with the birth control pills, the birth control pill pack for the carrier will be manipulated in such a way that the carrier's period will start first. And then prior to starting that period, she would have started a GnRH agonist to prevent her from ovulating. So A prime here is lining prep with estradiol begins. So the carrier starts her estrogen prep, which is about 12 to 20 days, and she's preparing her lining by doing this. We've turned off her endogenous estrogen production, so we need to give her estrogen to build her lining, and that's what we're doing here. After about 12 to 20 days, she'll come in for an ultrasound and progesterone level to make sure she has not ovulated, which again, she's on the GnRH agonist, so she will not ovulate. She should not. Between A prime and B prime, the intended parents are going through, and specifically the woman is going through the IVF stimulation process. She has her IVF stim starts with her cycle day 1, and she's going through the injection process like we described previously. Once her follicles reach a certain size, and after we've confirmed that the lining looks good, we will trigger the woman and then plan an egg retrieval and insemination 36 hours later. The day in between the trigger shot and the retrieval, we will need to start progesterone injections in the carrier. And this is kind of the point of no return for a fresh cycle, so to speak. So we have initiated the process of preparing the carrier's lining by starting the progesterone, and that's synced up to the timing in which the embryos will be inseminated, fertilized, and then cultured. So by the time the embryos are cultured out to the 5th day, so that's D here, the embryos in culture on the 5th day, the transfer will be performed after progesterone exposure that matches that matches 5 days of growth. So the endometrium and the embryo should be in sync at this point, D. The embryo transfer is performed. The one embryo is transferred into the carrier, and then 12 days later, we find out the results. Are they pregnant? Are they not? So that's how a gestational carrier fresh cycle would go down. Again, takes all the elements of one's understanding of the IVF cycle and just builds on on it. So I hope you found this helpful. I hope the application of assisted reproductive technology has helped giving you an understanding of why physiology of the menstrual cycle is important. And if you have any questions, please do not hesitate. This is, again, the first time we're doing this. If you have any feedback questions, please let me know so we can make it better for the next round.